Thank you, Joan. We're going to start our program. Each speaker is going to speak for about 25 minutes, and then we're going to open the session to questions. So if you have any questions that pop to your mind during their talk, we'll have a time after they're finished for about 10 minutes for each. And we're going to start this morning with Dr. Debora Simmons. She's an assistant professor at the School of Biomedical Informatics at University of Texas in Houston Health Science Center. She is a clinical nurse specialist in critical and acute care. She has a background in technology and complex patient care systems, and she is currently engaged in patient safety research, and she will be talking today about maintaining patient safety, particularly as it pertains to tubing misconnections. So if you please welcome Dr. Debora Simmons.
Well, first of all, this morning I'd like to thank you for having me here. I do a lot of speaking in my professional life, and I've got to tell you that I am most moved by the people that I see at this conference. Because honestly, at the end of the day, what we do is try to take care of people that have problems. You know, whether your problem is something that puts you in the hospital or it's something that changes your life, that's really what any good clinical person's life is about, is taking care of people. And that's what led me down this path of looking at this topic. And so today, I thought a lot about what I should say to you. I've been doing research in tubing misconnections for well over 10 years. When I looked at the very first case I ever investigated, it was in 2003, and I think our first publication was 2006. So I could come up here and I could talk to you about all these publications and all these different research things we did, but is that going to really make a difference for you? I'm not sure. And so I hope that what I do bring to you is something that is important to you that you can take home with you and help you face the days that follow this conference. I have no commercial financial interests. I don't endorse any products, and I wanted to say the opinions that, and I am an opinionated person, I do have to warn you about that. But they're all my own. And I also want to recognize Brian Patel, who was with the VA Patient Safety Center, Peggy Gunter, who you probably know from Aspen, as well as Nancy Pratt for supporting this research going forward. And those are really the people that began this many years ago when this was not a topic that was known. So how many people know what this is? Anybody? What is it? That's a Ford Pinto. So how many people know the story of the Ford Pinto? So this is those of you that don't, I'll tell you briefly, this is a really bad story. This is a story of a manufacturer that put out a car that had a design failure, so when it got rear-ended, it would burst into flames and people would die. And nobody really knew about that until they started doing research about it and they found all these cases. And then the engineers recognized, you know what, it's this one piece of this car that is causing these cars to go up in flames. And it's only under certain circumstances. And actually that piece cost $11. And so Ford and all their CEOs sat down and they looked at it and they said, okay, here's these pieces, and this is what we know is going to happen with it. And so what we need to do is change them all out. They're $11. And what they decided was that was too expensive because they recognized there was probably only going to be about 2,000 deaths related to it. And only 2,000 deaths, it only cost them about $200,000 a person that died. So they decided in a very well-publicized memo that they were not going to change the design of an $11 piece because of a death that happens. So what they did do is change their advertising, though. They used to say Ford leaves you with a warm feeling. So they did change that. And after the memo, we no longer have Ford Pintos around. Why do I bring this up? I bring this up because we have a Ford Pinto in healthcare, and that Ford Pinto is the Luer lock connector. And those of you that don't know about it, I'm sure there's a lot of you that do in this organization, know that we use Luer locks for everything that we connect in healthcare. So this is a picture of a neonate, and what you see is a feeding tube, an arterial catheter, central venous catheter. All of those have the same connector that connect to each other. That sounds kind of utilitarian, and yay, that's easy because now we can connect all these tubes, but there's one problem. In circumstances where someone doesn't recognize it, if you connect these tubes to each other, they kill a patient. And they kill the person that has these tubes immediately in most cases. These are physiologically incompatible with life when they're connected. If you put a feeding and an IV line, it's like pouring concrete into your heart. And that is the problem with Luer lock connectors. How many systems in healthcare have these? Well, so I'm going to stand in front of you and tell you this issue is really not about you in this conference, and those of you that deal with your condition every day where you have to deal with feeding and these Luer locks, this really isn't about you. What this is about is all of these different systems. These are systems where we have drains into the brain. We have connectors that go into people's lungs. We have connectors that go into blood pressure machines. We have all of these different connectors in healthcare and in acute care settings. Most of the patients that are really sick and really in problems have multiples of these connected to them. It's not unusual for them to have 10 or 12 of these, 20 of these connected in ICU. And when you're in an acute care situation, we have to change these tubes often because they get infected very easily, and these are very, very critical issues. So often these tubings are being changed every 24 hours. So now I want you to consider yourself a nurse that's got a patient that's got 20 of these, and you're having to change these tubings out every 24 hours. And now it begins to multiply, and it's over and over and over again. So when we first started this research, I'm going to apologize to you, we didn't think about you. You know, I was a critical care clinical nurse specialist in a big ICU where we were doing cardiovascular surgery, and the first case I recognized was in a neonatal unit. And it never occurred to me, and I'm going to apologize to you again, I never thought about people that, you know, go to Walmart with me, go to H-E-B, live their lives through with feeding tubes. But the end of the day is, it is about you, because you also have Luer locks in your life. And if you have to change your tubing out all the time, you also have the risk for this. So let me tell you how it happens. So I'm not an expert in nutrition or in feeding tubes. What I'm an expert in is safety. My science is human factor science, is the science of how people make mistakes. They say you teach what you need to learn, so I guess I needed to learn how not to make mistakes, and that's what I teach. So human factor science, we know this, that there are ways that people make mistakes and we categorize them. One of them is called an automatic mode. Now, you probably never thought about it before because you're in automatic mode all the time. Automatic mode is where your body is kind of on autopilot, and the more you do something, you don't think about it. So how many people went up to the coffee machine and said, okay, take my right hand, put the lever up, you know, put the cup underneath and do it? You didn't, because you know how to do it. And that's how your brain kind of works and gets these things done, so you don't have to have your attention on them. And the more you do something, the better you are at it. So think about when you were first taught how to drive, you were like, where's the brake? You know, the brake's here, this is here, where's my turn signal? And now when you're driving, do you think about it? You don't even think about it. Your foot goes directly to that brake pedal when you need to. And that is automatic mode. It's very important. There is no question about this. It happens, automatic mode is most often in familiar circumstances when you know how to do something. Here's the important thing about an automatic mode error. It's just like your brain skips a step. You know how to do this, and all of a sudden you got this little step that gets skipped. And you know this because this happens in your life. The important thing to remember is this is not detected by the person doing it. So because you do this all the time, you don't even recognize that you skipped that step. How many people have locked their keys in the car? How many people have locked themselves out of their house? I locked my keys in my safe. We dial the wrong number. We put milk in the cabinet and the cereal in the refrigerator. I finally got a new refrigerator the other day, and it had a safety feature where it beeps when you leave the door open. And I thought, and I know safety, I should know better than this. I thought, oh, that's cute, but I'll never use it. Then I came home the other day and I heard this beep sound. And I had left the door open all day on the refrigerator, and it was beeping. These are errors that you don't recognize happen. And unfortunately, they happen inevitably because we are humans and because this is going to happen because we cannot have perfect performance. So I will tell you that you cannot escape this error. You cannot escape it, and you will not know when it happens. And the particularly bad thing about this particular error is there's no grace. There is no period where you go, whoops, I left the refrigerator door open. There's no period where you say, there's a warning, don't do it. Right now, the way the design is, when you connect these tubes, someone's going to die. Because we are going to connect physiologically incompatible systems, and this is going to cause patient harm. This is without question. So there's some other questions, though. So who's endorsing this? Every major safety organization is endorsing this, and this is through the work of all these people that recognize this was going to be an error. We went to all these different organizations, we went to all the smart engineers, and we said, we've got to have a change. So today, as I stand here, you will see endorsements from the American Nurses Association, the Institute for Safe Medication Practices. The FDA has done a huge amount of work in this. Aspen, as a friend of this organization, has done a huge amount of work in this. There is no question this design must be changed, but the design has to be changed not only for feeding tubes, it also has to be changed for all of those other systems that I showed you. Because if we have those sitting there that can connect to each other, we're causing a danger for whoever's connected to those tubes. Because again, inevitably, someone's going to make a mistake. There's going to be a distraction, there's going to be something that calls your attention, or some flaw in performance. And it doesn't matter, I've got a bunch of letters behind my name, it doesn't matter. I'm going to make that mistake. It doesn't matter how careful I'm going to be, it doesn't matter. Because the design is that they will connect to each other, and if a human is connecting it, eventually it's going to happen. And these are the faces of people that live with this. This is Joanna Back, and this is Chloe. Early on, this is one of the cases that we looked at where Chloe, when she was in the neonatal unit, actually had a misconnection of feeding to her intravenous line, and she survived, but she has seizures today because of it. This is the picture of Robin. Robin was at term of her pregnancy. She was almost ready to deliver, but she had hyperemesis gravidarum, that pregnancy-induced condition where you throw up all the time. Robin had had it with her first baby, and she had it the second time around, and so they put Robin on hydration because she was constantly dehydrated from vomiting. This was usually normally, she usually had nothing wrong with her, but during her pregnancy, she needed this help. She needed this hydration. She got towards the end of her pregnancy, and this time on the second pregnancy, it got worse to the point that they needed to put her in the hospital. So she was near term, but they put her in the hospital and they put her on a feeding as well because she was not getting the nutrition she needed. And the thought was that they were going to get her stabilized and then they'd deliver her healthy baby. This was a healthy baby and a healthy mama ready to deliver. Robin's mother is Glenda. Glenda is an experienced obstetrical nurse and has delivered many babies over her years of practice. And Glenda was there with Robin during this day when the nurse came in and accidentally connected the feeding to the intravenous line. Again, like pouring concrete into someone's heart, Robin noticed immediately that the baby died. The baby was on a heart monitor. And then Robin realized that she couldn't breathe while her mother stood there. And Robin died knowing that her baby was already dead. This is a preventable error. If these connectors did not connect, this nurse that will carry this to her grave, and she will, I will tell you, the nurses that have been involved in this that I've talked to are some of the most grief-stricken, tortured people I've ever talked to, because they went to work trying to help somebody and they made an inevitable human error. So Robin had at that time Jarek. Jarek was 3 years old at the time. So today what I'm going to ask you to do is think about Jarek, because today he's 13 and he doesn't have his mother because of this. And I'm going to ask you to think about it because there's some things that we know that we need to think about as we go forward. The first thing you need to know is this is happening this year because of a law that was passed in California by Nancy Pratt. Nancy Pratt passed this law because there was chemotherapy that was put in the spinal infusion system of a young man, and he died an agonizing death over 24 hours. Again, not a feeding, but again, a lure lock connector that connects all of these things connected to each other. And Nancy went to the California legislature, and she got the law passed that said that California would change this. Immediately, the industry started reacting to it. They reacted to it in many ways, but I'll say one of the ways that I'm most disappointed in is that the manufacturers of these lure locks formed a lobby and put forward pressure on that law that delayed it for 4 years, that said we need 4 more years to work on this. So that law was delayed. This year, a decade, 10 years after we did these investigations, that law comes due. And that's really what is driving this, is that there is a law in California. Now, I don't know about your other states, they probably don't have those laws. So whenever this comes forward, it will be dependent on what you do yourselves to make it happen. We know today, without a doubt, that this is an error that needs to be fixed, and it's one that has been there for too long. You know, I'm embarrassed to stand in front of you and say I did this research a decade ago and it's not changed. We know it is present in almost every healthcare situation. I know today that there are people that live at home that have misconnected their own tube feeding. There was a young man that woke up in the middle of the night. He had both a PICC line and a tube feeding, and he accidentally misconnected it. I know that every major safety organization needs this to change, and I know that it's been 10 years. And I know there's no reason for you to tolerate this any longer, because these are the uncomfortable facts, and I'm not going to win any friends here, but I'm going to lay it out here. This is happening this year because of that California law, or it would not be happening. Because there is no reason that is consensus for keeping people safe that I can force on this industry to change this, other than that law. So I would ask you for support of this change and support of it now. I also know that GEDSA has brought vendors together to get consensus around what this design change is. And I know that one major manufacturer has pulled out asking to wait for another 3 to 4 years. And I will tell you, I find that unconscionable. I do not understand how anybody that understands safety can say we will wait another 3 to 4 years for this change and allow people to be unsafe for that period of time. All of this time during those 10 years, there are multiple cases again and again of this accident happening, and it's really time for it to stop. So I said it's not about you, but it's about this baby. You know, you're handling your conditions at home and everything you go through. I'm going to apologize for, because I didn't think that through, and I know it's going to mean that you're going to have to adjust your routines. You're going to have to find ways to make this work. But I do want you to recognize that if you have more than one line, you are at risk for this happening to you in your home, and should take well note of this. And if you are hospitalized and you have these connectors that are universal attached to your body and they put an IV line in, this puts you at risk. So I want you to be very, very aware of that. But I also want you to think of all the people that do this repetitive task in our healthcare organizations every day, because they're changing these tubes constantly. And it's really your voice that I need heard, because you are the ones that drive the healthcare system. You're the ones we serve. And if you will support this, it will be listened to. And I know there is a controversy right now about this new design. And what I would say to you is, there is no system I know of in this world that is perfect. And my grandmother would say that perfect is the enemy of good. And right now, folks, we have bad. This is not good, what we have now. So although we may move forward with a system that causes you inconvenience, I would say we are resilient people, we're smart people, and we will find a way to make this work. But it is above and beyond time that it happens today. So this is Jarek at 3 years old, and he's 13 today. And I hope that the next time that he hears something, he hears that the error that killed his mother is now resolved in the healthcare system, and we can go forward. And I would hope that all of you can think that, yes, life is inconvenient, and yes, there are problems with some of these designs, but yes, we need to change this because this is for the greater good of people. So with that, I'm going to leave you with that thought, and I'm here all day. Anything I can do for you, I am very, very willing to do. I appreciate so much your advocacy. I appreciate your voice for other people who are being hospitalized. I appreciate your voice for those that deal on a daily basis with their condition. Thank you.
Deb Stafer. Does anybody have any comments or questions for Deb? Go ahead. Do we have a mic somewhere? Here it comes.
Where's the question?
Right up here in the phone. No, here. I'm just telling her that you're bringing the phone.
Hi, thank you for that. That's completely new information for me, very interesting and terrifying. I'm wondering though, I'm not clear, are we looking at doing, is this a state change? Is this a national change? Where does the advocacy need to be directed? What can we do as far as, you know, like I don't know who the overriding body would be for us to contact.
So part of the problem is there's no regulatory overriding body that is going to say this is mandatory to change it. This is an international problem, by the way, if I didn't mention that. It's happening in every country. It's not just happening in the United States. And in the UK, they've actually changed to a different connecting standard because they had these and they brought forward advocacy. As far as your advocacy, it always starts at home. You know, the more that on a grassroots level you can go to your healthcare providers and ask for it, the better. It is right now in an international standards organization. There has been an expert group, and by expert group I mean people that are engineers and experts in this area, have been working on this for 10 years. And I believe they are going forward with a standard. The vendors, the GEDSA group, and I think Tom Hancock is here to represent them today, has put together a standardized connector as well to move forward. Again, my science, I don't really care what the connectors are as long as these things don't connect to each other. What I do care about, though, is the delay. So the connectors are moving forward. I would ask that you support that. But your advocacy is always welcome on the FDA level, on the national level, and certainly you need to be talking to your local folks about this, because that's where you're going to go if you need acute care. You're going to go to your local hospital.
Debbie. Hello.
Yes.
I think one of the issues here is that a lot of professionals in the field did not appreciate until quite recently how many of consumers at home actually opt to blend normal foods and therefore need a delivery set that can tolerate that kind of consistency. And in general, the people that do it feel without perhaps a lot of science, but nonetheless they feel that their child or whoever has made serious progress. Now, in terms of trying to unwind, because this issue was not in front of the committee that was making these decisions, they were very hospital-oriented, and this whole group of people, therefore, were not at the table. So in terms of going forward, because there has to be a solution, and it's not probably that hard, but people need to know exactly how to do it in a way that is effective. So
Absolutely.
it's somewhat what you've just said, but I think it needs to be really, really clear.
So again, any solution that you put forward in a design change is not going to be perfect, and certainly we've left out that group. What I would ask you to do, because I am not an expert in blenderized diets, and I certainly want to maintain your ability to choose for yourself, is to get a special group together and start looking at that and see what your options are. This is not unusual that we have a problem with a design. We can get past this. You know, what I would hope, though, is that we do get a special group together, and certainly this organization has the expertise for that, and then get your menu of options so that we can get past it.
Yes, I appreciate your, thank you for your presentation. That was very informative, very interesting. I want to say that nobody values human life more than me. I think we all value human life. We don't want to see anybody hurt or some death happen because of a misconnection. However, the other side of the story is that I'm a tube feeder for 4 years, and one thing I don't understand is how can you implement a California law that says no enteral misconnections can happen when in-fit connectors will still misconnect with other things, shallow trachs, intravenous cannulas, and so forth. I got 3 things listed here. And that's kind of disturbing how California can do that law, and the law is in violation of itself, in fact, when you pass a law that says that.
Are you familiar with what the law says?
Pardon me?
Are you familiar with the wording in the law?
Yes, ma'am, I have a copy of it.
Okay. So,
I've written legislatures in this state about it.
okay.
I know it's AB 444 and AB 1867, right?
Right.
Okay. I get concerned about blenderized food with a 2.9 millimeter diameter. You just can't do it. I've tried it. I've tried it with infit. I've tried it the regular way. It just doesn't work with infit. It just won't
Okay.
go through. You'd have to have so much force that you can't do it.
So it sounds like you've got a lot of different issues that you've identified around it,
I do.
and I
There's-
appreciate.
There's
I
6 or
appreciate,
7 issues. I'd like to talk to you after the meeting if that's possible.
Absolutely. I'm
That'd be great.
available to any of you all day, and there is a special session this afternoon as well. And I'm here all day and available to you all. And any of the materials that I have, any of the papers I've written, anything I can do to help you, I'm very willing to do. Absolutely willing to do. We still have some things to work through, and the hospitals have a lot of things to work through. There's a lot of things with supply chain. You know, I want to make sure that anybody that shows up with an old fitting in the emergency department, we can take care of them. There's a lot of things we need to work through. That's a good point, sir.
Dr. Kelly next. Get Dr. Kelly to come back.
Okay, a couple of things. Excellent talk, Deb. First of all, at least half of this audience is being fed parenterally too. And so they're at risk as well with their misconnections. But I wanted to make people aware that the Oley Foundation is meeting on a regular basis with FDA,
Wonderful.
gets some of the engineers, and one of my colleagues who's in the back could maybe speak to this as well. But they are designing studies on a variety of different tubes, different sizes, et cetera, that are underway now. Also, there have been some manufacturers changing their designs, which is probably not known generally among the audience or among a lot of people. So Oley is certainly working to try to get some things so that our population can benefit from it.
Now, I appreciate that very much, and like I said, this is a huge change for healthcare. If you think about it, all these years we thought that this was okay. Now it's not. We've got a lot to change, and so I appreciate your support.